On May 17, 2026, the World Health Organization issued a global alert regarding an Ebola outbreak originating in Central Africa. They declared it a public health emergency of international concern, or PHEIC. Under the international health regulations, this is the highest level of alarm the WHO can trigger. A PHEIC designation is a specific legal tool accounting for factors beyond a pathogen's mortality rate. To trigger this protocol, a situation must meet three strict intersecting criteria, shown in this matrix: an extraordinary localized event, documented international spread, and an absolute requirement for coordinated international action. To understand why this specific declaration was made, we have to look at the exact epidemiological data that breached that legal threshold. The data begins in the Democratic Republic of the Congo, specifically within the health zones of Ituri province. Containment here faces severe environmental friction. Ituri is an area experiencing a protracted humanitarian crisis, characterized by extremely high population mobility across rugged infrastructure. While the initial clusters emerged in these rural health zones, the threat profile escalates significantly when cases begin appearing in dense, highly connected urban centers. This risk is compounded by the specific pathogen driving the epidemic, the Bundibugyo virus, a distinct strain of the Ebola virus. When you combine a hemorrhagic virus with a highly mobile population in a fragile, conflict-affected geography, the localized outbreak rapidly scales into an international challenge. This first panel shows the initial metrics reported from Ituri: 8 laboratory-confirmed cases, 246 suspected cases, and 80 suspected deaths. The true anomaly lies in the initial testing ratio. Out of 13 samples collected, 8 returned positive for the Bundibugyo virus. That exceedingly high positivity rate suggests the surveillance network is only catching the sickest patients. It indicates a massive gap in detection, meaning the actual size of the outbreak is likely much larger than the official counts. This uncertainty triggered a high alert response when an individual returning from Ituri arrived in Kinshasa, a major metropolitan center, showing suspected symptoms. Fortunately, confirmatory testing at the National Institute of Biomedical Research returned a negative result. This proves how vital centralized, highly accurate diagnostic facilities are for cutting through the noise of syndromic surveillance. The event's extraordinary classification stems from the massive gap between these official figures and the unquantified number of infections likely circulating beneath the surveillance threshold. A major factor contributing to those undetected infections is nosocomial, or healthcare-associated transmission. Early in the outbreak, 4 healthcare workers in the affected area died after exhibiting symptoms compatible with viral hemorrhagic fever. When medical staff become infected, it points to systemic failures in infection prevention and control protocols, such as inadequate personal protective equipment or improper triage. This exposes the most critical vulnerability of this epidemic. Unlike the more common Ebola Zaire strain, there are currently 0 approved therapeutics or vaccines specific to the Bundibugyo virus. Without these medical countermeasures, local clinics in a fragile health system stop functioning as containment zones. Instead, they act as amplification hubs, accelerating the spread of the virus. That accelerated local spread rapidly satisfied the WHO's second requirement for an emergency declaration: the international spread of the disease. Authorities reported 2 laboratory-confirmed cases in Kampala, Uganda, resulting in at least 1 death. This map traces the movement of those 2 individuals. Both had traveled directly from the Democratic Republic of the Congo, and their cases were reported in Kampala within 24 hours of each other. Halting this vector requires strict clinical isolation. Confirmed cases must be held in specialized treatment centers, with all national and international travel prohibited until they produce 2 negative tests at least 48 hours apart. The rapid cross-border leap of a pathogen with no known cure provided the definitive evidence needed to breach the WHO's threshold for an international emergency. This triggers the third requirement: mandated international coordination to scale up the response. Because there is no vaccine, the WHO directs affected states to rely entirely on classical epidemiological interventions. First, authorities must establish decentralized laboratory capacity across key health zones to reduce the turnaround time for Bundibugyo testing. Second, they must build specialized treatment units near the outbreak epicenters, staffed by personnel trained in optimized intensive supportive care. Third, they must mandate strict protocols for the safe and dignified burial of suspected cases. Human remains are highly infectious, and proper handling prevents further community transmission. In parallel, the WHO requires the urgent implementation of clinical trials to evaluate candidate therapeutics. These directives legally mandate an operational pivot toward the mechanics of disease containment required in high-risk, low-resource environments. When an international health emergency is declared, neighboring countries often face intense political pressure to completely seal their borders. However, the WHO issues an explicit, scientifically backed directive: do not close borders or place restrictions on travel and trade. The epidemiological logic is precise. Hard border closures push the movement of people and goods away from official checkpoints and into informal, unmonitored crossings. This effectively blinds the surveillance network. Instead of closures, the WHO mandates rigorous exit screening at major land crossings, seaports, and international airports, utilizing temperature checks and risk assessments to intercept the virus before it travels. Open borders with active screening maintain visible, actionable data lines. Closed borders generate invisible transmission maps. Ultimately, a public health emergency of international concern serves as an operational blueprint to mobilize resources and standardize global defense. The Bundibugyo epidemic presents a severe mathematical threat: a fast-moving viral strain with no medical cure, exploiting the systemic vulnerabilities of a highly mobile population. To contain it, global health networks must rely on strict infection prevention, decentralized surveillance, and localized community cooperation to buy time for clinical trials. Navigating this emergency requires strict adherence to scientific data, choosing transparent monitoring and targeted intervention over the political illusion of total isolation.